It was a 2-to-1 randomization, non-metastatic. They could have lymph nodes in the pelvis, and they had to be less than 2 centimeters. I didn't see the calculations in the New England Journal on how they did the PSA doubling time, but they were all defined as less than 10 months, rapidly rising. And I think that's important as we look at these patients who come in who should get this treatment with the considerations that we just talked about. And they did some substratification. They were looking at this new to urology space metastasis-free survival endpoint. They had secondary endpoints as listed there, similar to what you just heard. And they also had a couple of other endpoints, the second progression-free survival, which I have a slide on a little bit later. Similar to the patient population that you just saw, these patients were generally healthy men around age 74. Many of them had doubling times calculated, less than 6 months even for a third of them. There was a small usage of bone-sparing agents, about 10%. About 20%-ish had nodes measurable in their pelvis at the time of entry. And their primary endpoint, similar to the previous primary endpoint, there was a 72% risk reduction in progression or death in these men, and that was highly significant. Like this previous study, they had forest plots. The substratifications are listed there. It really didn't matter for almost all of the subcategories. There was benefit demonstrated across the groups, including for the 2 splits on the doubling times. Secondary endpoint, now this is where we can debate what would have happened if we just left them alone, but in general it was about a 2-year difference in time to development of metastatic disease using these conventional images, and for some patients that's a pretty powerful 2-year time frame. This was symptomatic progression, also highly statistically significant, with a 55% risk reduction in symptomatic progression. Oops, sorry, went a little too fast there. This is the overall survival. Again, we're not close to the medians in terms of the follow-ups. There was a 30% risk reduction in death in this category, but longer follow-up would be needed to see if they can hit a statistically significant, but nevertheless. The quality of life data, because we're taking asymptomatic patients and treating them using 2 validated scores, they did not see any diminution in the quality of life in these patients who were treated versus those that were observed. They did have a fairly significant amount of secondary treatments when patients progressed. About half of the patients in the treated arm and about 78% in the observation arm. About 75% of both of those that were treated with either abiraterone or enzalutamide, so high use of Abi in the secondary subsequent treatment. This was that second exploratory endpoint, so they looked at time from initial randomization and then progression on that subsequent treatment, and again showed a 50% risk reduction in progression here. So that's an interesting finding that is out there for consideration. Adverse events this was fairly well tolerated. These are the adverse events that we're seeing, and a lot of them were class specific, but unique to this group were the prevalence of a rash seen in about 20% of patients. Also hypothyroidism, which was detected, I think, in about 6% over the observation group. Very small amount of seizures, but the other side effects were pretty similar for that or enzalutamide. So in conclusion, apalutamide decreased the risk of metastatic disease by 72% and extended that median metastasis-free survival at least for about 2 years, and the benefit was seen across the subgroups. They had fairly positive also PSA, progression-free, etc. in terms of that. Apalutamide was associated with a 30% risk reduction in death, not statistically significant, but again, follow-up was cut short by the data safety monitoring because of their primary endpoint hit. And most of the patients who were in the placebo group did go on to get secondary treatments, as we talked about, and for some reason, the patients in the apalutamide treated group seemed to fare better even with that second treatment added on. And it was well tolerated, and overall it did get published, and now it is in most of the new guidelines for patients with this disease state of M0. So it's in the NCCN and soon to be presented at our AUA in about 2 weeks, and this is the NCCN guidelines. Again, it does mention the doubling time and hopes, I think, that most people will be judicious and not extend this treatment to all patients in this space. I think that's it. There's a summary comparator slide for the two studies, but with that, I'll open it up to questions.
So, I like to say is one of the things that is great about clinical trials is it kind of smooths out the edges. We do clinical trials so you get the average. The problem is we never treat an average. We treat an individual patient. And when I look at this data, it's very positive. Both these trials are very positive. The question though is, what is the right patient? So right now, you walk in the office, patients sit down in front of you. Which is the patient that you're going to say preventing a metastasis at this time, or in the next 4 years or whatever, is going to be clinically meaningful for this? Is there a type of patient that you say, this is really the type that I would say I want to do this, it's going to be worth the cost, it's going to be worth that? Do you have something in your mind right now? Because obviously you're saying a 92-year-old patient probably is not as important. Maybe, though? What's
Younger is better than older. I think we would agree to that. I think the overall magnitude of their PSA has to be kept in the context. I mean, patients were allowed in this trial with lots of PSAs, but the higher the PSA, the more likely the disease burden. Certainly the rapidly doubling PSA patient would soon develop or blossom, even with conventional imaging, metastatic disease, which often then becomes symptomatic in that. So I think the younger they are, the more aggressive their tumor appears based on at least PSA kinetics, and the overall PSA would be drivers in the decision making.
So is there also then the flip side? Is there a patient who comes in that you would say there's no reason to use one of these drugs? Like, is there an age or a comorbidity or something like that? You kind of say, these are, I don't really think the discussion's appropriate.
Well, all of these patients had good performance status, right? So right there off the bat, especially since these are non-metastatic patients, their performance status is going to be secondary to other disease states. So poor performance status patients, I think those with a smoldering or a very low rate of rise, and you may even select patients with low PSAs overall to simply observe.
Is apalutamide any different than enzalutamide in your mind?
Well, it is different in terms of some of the side effect profiles. They have similarities and they have some differences. I think there were 10 deaths in the New England Journal paper for apalutamide, and there were like 30 deaths in the other one. Not really sure of the details on that. I think there was 1 death in the placebo arm in the apalutamide study. So I think they're similar in class, and they're generally similar in mechanism of action. I'm not sure because we've only started treating patients if I am going to see similar, say, CNS side effects and that sort of thing. But there's definitely fatigue, there's falls, there's some fractures in both of these studies.
I think apalutamide came out looking not as good as I thought it would on this study compared to the phase 1 and phase 2 experience, because there were some falls. There was, it's poorly documented, but cognitive issues were seen in this study. And it didn't look as good as it did in the phase 2 study. I still think it's better than enzalutamide in terms of its toxicity.
Yeah.
Just the rashes.
Rashes,
When rash
yeah.
happen,
The rashes are different.
they're really difficult to manage.
Yeah.
At least initial 1 or 2 months.
Yeah.
They do get better with dose modification.
Yeah.
But all the patients I've treated in Titan trial, the first MA, like hormone sensitive trial, rashes were quite difficult
Yeah.
to manage.
I leaned over to Oliver and I said, I wonder what NICE will say about apalutamide in the UK. And I was doing, as you have this up here, I was doing the calculation. NICE always looks at overall survival, but if you look at progression-free survival as a 35 or a 25-month difference, you're spending $250,000 to delay metastasis in a patient without a known survival benefit. And I think I keep coming back at the cost, because in the latitude setting, for example, I'm getting patients with abiraterone copays of many, many hundreds of dollars a month with sort of a, expectation of continuous therapy. So I think I'm sort of wondering if this is going to be where the rubber hits
Well, I
the
mean,
road.
remember Nick James at the meeting during the discussion, and Nick obviously knows pretty well how NICE
suppose,
works. He
yeah.
said there was no chance.
Yeah, zero chance.
Zero
yeah.
chance.
Yeah.
Okay.
Yeah.
Yeah.
I just read a headline about the healthcare bubble is about to burst this morning, and I just see this here.
Just a quick note. Does anybody know what the CNS penetration is like for apalutamide? Because fatigue was clearly less than enzalutamide, in my experience.
I don't know what it's supposed to be negligible, but there were falls and things. I mean, I don't know why people are falling. And then there were also these, what was the word that they used to define the change? They didn't say cognitive change, but amnesia or something. I mean, it was some weird word. It was reported in their CTCAE.
Do you want to plug your study, Dr. Morgan?
No.
No.
As a follow-up to John's question, I think, why don't we vote with our feet? And let's assume that you're in your mid-60s and you have a PSA rising doubling time of less than 10 months. How many in the room would want to take therapy in that indication with your hand?
Who wants to
There you
just
go.
wait for the Met to come?
Or, yeah.
The MET doesn't come with spinal cord compression. The MET comes as a subtle shadow on the bone scan.
We're not sending people off on a
first one.
unicycle tour to China. I mean,
Right.
that's the key here, is that a lot of the degree of the metastases and the implications are not the same as they would have been 10 years ago. These patients are closely followed. We don't let people, unless they disappear, they don't present with significant symptoms.
But I think the real hope isn't that you just stop at this. This is the end all be all. It's how to, maybe they should have been treated before they ever developed this state. Maybe there should have been a different way to treat the primary tumor that maybe it was left behind, or some of these small volume mets that are now signaling out for these other problems that we couldn't see on
I
conventional
don't think there's any
imaging.
question that, the whole concept of oligometastatic disease, are there people we can cure? I mean, that's really the holy grail here, but this is a broader brush.
But I guess what I'm saying is that this is probably very effective therapy, but are we still way late on when we should be giving it? And where in the disease
and
spectrum?
those
early
studies are
versus
going to
late,
happen,
right?
Mike.
It's early versus late,
Yeah.
because if it's not different, then
But we approved, docetaxel in the day with a 3-month overall survival advantage in the end stage of CRPC, and that was big
Mike,
news.
The other thing, though, is that docetaxel is probably still the most effective palliative therapy for any solid tumor.
I agree, but it's because we're using it earlier.
No. I'm talking about in the castrate metastatic setting.
I think, one of the things that we should, at least that I emphasize as I'm thinking about these drugs to myself is, patient stratification. So I try not to put patients on ADT in the first place when they have biochemical recurrence, given the lack of data to suggest a clear survival benefit. And I would say there are some patients, clearly with a short PSA doubling time, that I do put on ADT, and that patient population may end up in this group. But, it's interesting to me that the label does not include that PSA doubling time. That, I think, is a mistake on some levels, because there are people who will broadly apply this data. But for the right patient, I think that it's reasonable. I also wonder about that second PFS endpoint, that exploratory endpoint, that's kind of weird. But if you look at it and try to sort of tease it out, there is a question, or at least I have a question, of whether or not you can make up the time, whether or not knocking things back at an earlier time point is potentially more effective than adding things later. And I think it's, like I said, I think it's very hard to tease out. But if you look at just the progression on APA versus the progression on ABI and the time difference, I mean, it is slightly longer time to progression on APA than on ABI and the placebo arm.
Alicia, you'd really have to properly design the trial, and it wasn't designed. It was dealer's choice at the time of progression. So in order to really answer that question, which I think is important, you have to mandate that as soon as the metastases appear, that people all have access to a drug that is known active. That wasn't the case. So it was the opportunity to cause mischief here in a post-progression setting is large.
Yeah. Well,
We better get going, but I'll tell you what, it's great.